Last Wednesday, we launched the first episode of our Heart Health Month series, Running Out of Time: Why Black Hearts Are Failing Sooner, with Dr. Anthony Fletcher and Dr. Sandra Bruce Nichols. Today, we continue the conversation, going deeper into what's happening, why it matters, and what must change. Welcome back to Running Out of Time.
Age, what are the earliest moments where intervention can actually change the story? Either one of you can start.
The age is from birth. It starts with how we learn to eat, the nutrition that starts to pass our mouths when we go from perhaps breastfeeding to eating regular foods. The teaching of the palate is a very important role here. I mean, many of us learn how to eat from our grandparents, and our grandparents taught our parents, and our parents obviously continued that through us and how we teach our children. So that's the first step from day one. We start talking about activity levels. Unfortunately, we have so many obese young infants and young children, but we need to encourage our children to remain active, to exercise, to play, to minimize their computer time and their game time. That's all fine and good, but you've got to get out there and get exercise. So you start your health from the day that you take your first breath. You look at the environments in which we live. We need to advocate for our communities to have safe play zones so that our children can go outside and run and jump and play and ride bicycles without fear for their health or their safety. That's extremely important. We keep our physical examinations preschool, during school, our physical examinations for our athletes as they go into competitive sports. As we become young adults and young executives, that we continue with that screening process. We know our family history. What am I at risk for? What runs in my family? Doesn't mean it's going to happen to me, but I need to look out for those particular entities as potentials. I cannot tell you how many times diagnoses have been made by myself based on the family history. The symptoms may be very unusual or very bizarre, but if you tell me that your father had a heart attack, your grandfather had a heart attack, your brother has a stent, and you walk into the office 20-year-old saying, I just don't feel really good, I'm going to focus on that family history and be sure that we screen you appropriately. That's just extremely important, that we recognize that early prevention, early diagnosis is key. Again, I tell my friends all the time, if they say, hey, if I ever have a heart attack, I want you to take care of me. My motto is, talk to me the heartbeat before you need me. We have the most potential opportunities then. We can modify things. We can change things. We can prevent the fire. Putting the fire out, we may be successful, but there's been some damage. So that's key. We need to work early with our children, our preteens, our teens. That's when we start.
Dr. Fletcher, I'll never forget the opportunity of serving as the Commissioner of Health in Arkansas during the smoking periods. And when the campaign came about that says, just say no, the health department there in Arkansas, real focus was on youth, was on the rally. I believe it was the First Lady Reagan who started the campaign of Just Say No. We chose to work with that campaign with elementary school children, with kindergarten children, and junior high and high school children. We were so amazed that campaign was so successful in Arkansas. In fact, we had number of quotes, number of videos where children would go home and say to their parents, you're not smoking in here. And would actually had parents to come to school and say, what are you teaching our children? They're destroying our cigarettes. And as you know, after during that campaign and after that campaign, we saw a major decrease in the number of people who were smoking. I believe it's so important, as you stated, to start at birth, beginning to make sure our children know to say to their parents, I'm not eating that. And it's so amazing because even with my own daughter, who's certainly not a child at this point, when she said she wouldn't eat something, the family kind of went in that same position. It wasn't something we would put on the table very often. So it's just, and what you're seeing, Pam, is the contract and the back and forth between Dr. Fletcher and I, as he's giving you all of the magnificent cardiac information and how to manage. And I'm really talking real person, real time family households, because there's no question who's the expert here. Although I am a physician by training, but I'm just always in awe of all that Dr. Fletcher has done in order to make sure that cardiac disease is discussed in communities. It's so important to start at birth if necessary.
And I don't know this because I just don't know this. Are they teaching health care, heart care in elementary schools, in middle schools, in junior high? Do anybody know that? Because as big as it is, what percentage now do African Americans, us Black people, what percentage are experiencing heart problems? Are we in the 15%, 18, 20%?
I will say that percentage wise, African Americans have the highest amount of heart disease. We lead the nation in death for cardiovascular disease. African American men have the highest mortality rate for cardiovascular disease. African American women are the highest of the women group for cardiovascular disease. And that's one of the reasons why this is so important today.
Yeah.
Even though we're getting better with cardiovascular disease treatment and cardiovascular disease sort of aggressive procedures, the gap still persists between people of color and non-people of color for cardiovascular death. And that is one of the things that we're focused on. How can we change that gap? And you talked about hearts failing early. Well, that's one of the reasons that we have the gap. Hypertension, for example, is one of the major cardiovascular conditions that affects us so early in life and sets the stage for so many devastating cardiovascular diseases and complications. And so we've got to figure out how to close that gap. And it starts with our youth. It starts with, our diets. It starts with our activity levels. It starts for sure with education about how we present. There's a lot of social determinants of health, which that's a whole discussion across the board on another day, that contribute to that because, genetically, we're not inherently cardiovascularly more unhealthy or unfit than our other counterparts. But I think that's the key. We have to look at what we can do to change that gap. And so more frequently, we die younger. We die with more potential morbidities and complications from our cardiovascular illnesses than our non-Black counterparts. And that's part of what this is all about in terms of the furor of the discussion, in terms of why we want to try to be impactful with conversations like this today, in terms of helping our people, our populations understand that we can change a lot of what happens to the cardiovascular health. And a lot of it starts with us changing our lifestyles.
The thing that I love about this conversation is that when you follow the instructions that just was laid out by Dr. Fletcher, you not only improve your cardiovascular health, but you improve your health from a hypertension, which is known to be the silent killer. You improve your health from a physical perspective, which helps with cholesterol being elevated and other diseases that may be secondary to the abnormalities of the things that we're talking about, such as not exercising. Obesity certainly does cause hypertension, but it also causes diabetes. And you can go down the list. So when you take this simple prescription that was given today around the exercising, knowing your family history, being able to know what you're putting in your mouth, understanding the calories, understanding getting your family moving as well and making it a family, a generational model, you truly improve your overall health care. And clearly, I can tell you the most important organ in your body is the heart, because you can live with many things, but you cannot live without a heart.
This episode, the reality, wow, that's a lot to take in. The numbers that you've shared, the reality of being overworked, stressed, a physician herself having a transplant, and the reality of some of the great work that Dr. Fletcher talked about with ABC, that organization that he's the president of, I think the 20th president. So congratulations on that. Symptoms aren't subtle. They're ignored. We're going to talk about the missed warnings. Dr. Nichols know about missed warnings. She's going to tell you her story and what she learned about those missed warnings. Dr. Fletcher is going to tell you about people that have, come to his office, and things that he said in the first episode. Dr. Fletcher mentioned getting their family history on both sides. And we're going to ask him, what do you do when you don't know your family history? Because again, in our community, that can happen. It's foster children, adopted children. So we're going to go right into that, and we're going to ask them about the missed warnings. Either one of you can start off.
In hindsight, there were many symptoms that were present, but I just didn't have time to recognize them. I didn't want to admit that they were occurring. I didn't have the time to ask why it took me longer time to walk through the airport, why I was short of breath, why my mother would say to me when I would come home and would be lying down sleeping, she was just saying, why are you breathing so abnormally? And I would just say to her, Mom, I'm just tired. The day that I died, the week that I died, I had been to Utah, to California. I had also been to Minnesota, which is the corporate office is located. I had driven to the Eastern Shore, a 3-hour drive, and turned around and drove back. I stood in my bathroom ready to go meet with some executives at Johns Hopkins because my job required that I do these things. And Sandra Nichols was not going to be less than the best than what she was doing. So I stood in my bathroom and I was curling my hair. My daughter was there and she was talking to me. My daughter, Makiste, said, "Okay, Mom," and she turned around. The rest of the story is what someone has told me, particularly my daughter. She said she heard a thump and she turned around and I was incontinence to bowel and bladder. She had to pull me out of the inner part of our bathroom, not knowing that she was pulling my curling iron with me. She immediately, bravely, as I'm really shocked as to how brave she was, bravely not only begun CPR, but called 911. Within minutes, they made it to my home. They had to work extra hard. In fact, it was an extended period of time. When I was lifted off the floor, they finally got a heartbeat and lifted me off of the floor. They found my curling iron, which had burned, a 6-inch burn through the muscle of my hip. They got me to the local hospital, and the doctor who ran the code in the emergency room told my daughter, told my husband that if I lived until the next morning, I would be brain dead and that they need to start looking for some type of care center for me. My daughter refused to leave my side. She sat in what she said was the coldest room that she's ever been in her life. She watched as they ventilated me and got me set up to see if I could be stabilized. She remembered that I had a meeting at Johns Hopkins that day, and she took my finger and warmed it and broke into my phone and got the leadership there at Johns Hopkins and said to them, "My mom died today. It's why she did not make her meeting. She had a massive heart attack. Can you please help?" Within hours, a helicopter came over to the local hospital, which was Shady Grove, and they helicoptered me to Johns Hopkins. I will continue the rest of the story as we go along, but I think the question that you have here is the reality. The myth is looking at and what are the missed warning signs after the reality. The missed warning signs do tell you that they're there, but you must listen. And so in hindsight, the symptoms were there. The actions could have been taken, but I just didn't do my best for myself.
Dr. Fletcher?
Certainly, Dr. Nichols' personal description of her signs and symptoms are very impactful. As we all know, heart disease in women often has different symptomatology, different presentations, especially when we talk about heart attacks. Classically in men, we talk about heaviness, tightness, fullness, center of the chest, radiating into the neck, the jaw, the arm, the back, maybe some shortness of breath, maybe some sweatiness. And women can have those same symptoms, but often, sometimes they present with fatigue, shortness of breath, abdominal discomfort. And I've even had someone present with a toothache. But essentially, I think the important part about recognizing the symptoms goes back again for me for education, knowing again the potential risk factors for cardiovascular disease. Do you have any of those risk factors? Knowing your family history. What is the likelihood that these symptoms may potentially beat your heart? We see people all the day who have nausea and vomiting and shortness of breath and abdominal pain and chest pain. And very often it's very difficult to sort through those symptoms. But I think the most important part of it is, again, to risk stratify their profile for what are their risks for having heart disease, what are their underlying conditions that predispose them to heart disease, and to be heart disease until proven otherwise is the way that I approach that approach in terms of making sure that you're making the appropriate diagnosis. Again, I think it's extremely important that people understand and advocate for themselves, that they let their providers know that, I'm worried that this might be my heart. Many times people will say, "Oh, it's just GI, it's just a little bit of anxiety." And it certainly could be those things. But I think as a healthcare professional, especially when you know the risk profiles of individuals, it's your job first to be sure it's not their heart. And then all the other things, we can fill that in a little bit later. I think The other point that Dr. Nichols makes so very, very clearly here is the fact that her daughter played a very role in her survival. I firmly believe that every household should know how to do CPR. Every educational institution in this country, you ought to have some sort of prerequisite at some level, whether it's elementary school, high school, that you are certified in doing CPR because you could potentially impact not only members of your own family, but also your neighbors and colleagues. So I think that's really key that Dr. Nichols' daughter was able to perform CPR to keep her viable until the EMS got there. So I think that's extremely important that we are able to communicate our concerns, our symptoms, and be aware of the fact that, hey, even though this sounds like it might just be a little bit of anxiety, my mother, my father, my brothers, they had cardiovascular disease. So I'm concerned that it might be my heart. Let's check some heart things just in case. You can give me an antacid or put me on an H2 blocker for elevated gastric secretions, but I want to be sure that my heart is checked out okay. And I think if we do that, we'll be less likely to miss opportunities early to be impactful. The story is often told where somebody comes to the emergency room with GI upset, they're seen, treated, sent home. 2 hours later, they come back, they're in with similar symptoms, they're treated, maybe triage, sometimes still sent home. But again, if you look at that history, if you look at what are their risks and you assess that risk, you can be less likely to miss the diagnosis.
Thank you both for that. I know that some people, they go to their primary care physician, and some people have to prove their pain. And even when they take the test and their primary care physician say, you know what, I want you to go see a specialist. It might be 6 or 8 months before they can get in to see that specialist because they're just so booked. I just recently saw something, I think it was Congress, they were talking about even a physician himself, he had the symptoms and it took him a while to get in to see people, even with the privilege. And so, all of this, it can stop a person, even if you know something is wrong. But if it takes 6 to 8 months to be able to get in to see you, Dr. Fletcher, what do people do? How do you start to advocate then? Because that's what your primary care physician have told you. You have to wait that long to see somebody that specializes in my condition or what I think I have.
Certainly, there's a workforce limitation in terms of availability. Again, cardiovascular disease is so prominent. There are so many people who have cardiovascular disease. The number of physicians who are available as cardiologists certainly can be a role. The location of those physicians, as we talked about the cardiovascular deserts, sometimes people are traveling 80 miles or more to get to a cardiologist. The other component is even the fact that in many cases, they are not even referred to a cardiologist by their primary care. And that's really key, that sometimes they are not even given that opportunity to be referred. The primary care provider thinks it's something different, or for whatever reason, they're not as aggressive with that referral. That plays a significant role. I think the role also of healthcare provider extensions, nurse practitioners, physician assistants, they can help us in alleviating some of the burden of, the number of people who need to be seen versus the spots. I think we need to look aggressively at how to streamline the system. With the EMRs, there's pluses and minuses to those. In many cases, they're efficient and they help with documentation and access. But in some cases, they slow down the number of people you can see because of all the steps and clicks and things that you have to do. But we can get into this deep prior authorization. That's a whole nother issue. You have to have prior authorization before you can even see the specialist. Or if you see the specialist, if you want to have a test ordered and the person lives 80 miles away, but they have to be prior authorized, well, guess what? That person leaves your office without the test that you feel is appropriate. So there are many aspects to this. But again, we talked earlier in the previous episode about the diversification of the workforce, making sure that you have a larger number of physicians who are able to see patients. And again, as I said, I think there's great promise in the nurse practitioners and the physician assistants to also advance or increase the number of spots that are available. You don't always have to see the cardiologist, especially if it's follow-up in terms of regulation of blood pressure, cholesterol medications, et cetera. And that will avail the cardiologist more time to see the more complex individuals as well as the new patients. And so there are many ways I think that we can look at this, but certainly that's true. Sometimes you do have to wait to see the providers just because, again, supply and demand. There are only so many people who can meet the demand, and certainly that can play a role.
And Pam, it's really challenging now that we're seeing the decrease in the number of hospitals and the number of providers that exist. So a lot of the doctors are burned out. A lot of the doctors have decided since COVID to go ahead and retire. Many of our rural hospitals and lower patient count areas are being closed. And there are multiple things that are out there today that should be helpful in those challenges, but certainly they are there. And so when you look at that from the perspective of can ambulance service be expanded to where they can pick up those patients 80, whatever length away, and obviously 80 miles with someone who's had a massive heart attack, or that length of travel does not guarantee that the best care can occur in the back of an ambulance. Certainly very professional, many lives have been treated, but there's just some things that those patients do need to be in to see the actual cardiologist, and some interventions that need to occur very rapidly. So as a nation, we really have some challenges today with some of the things we're seeing with Medicaid, with Medicare, some of the things that are not being covered today, some of the things that are being challenged today. We're really seeing a challenge in the healthcare of the people of our nation. And I do think it's important for us as professionals, as individuals, to advocate for those, whether it's health equity, or to advocate for those to receive the care, because in my humble opinion, healthcare should be a privilege that we all have access to.
I agree with that. Since this episode is about missed warnings and the percentage for Black males is so high, I really want to talk about that and dig in deeper, Dr. Fletcher. What you hear about young athletes out on the training field, 19, 20, 21, and they fall with a massive heart attack. So at that age, what are the missed warning signs in young people? What are the missed warning signs that are in middle-aged men and older men? What are they missing?
If we start with your young athletes, many times there are no warning signs. They're young, they're healthy, they have good blood pressures, and they've not had any congenital heart issues or problems, and they're in excellent shape and condition. They're running full 450s and, bench pressing 300 plus pounds and squatting 600 pounds. They're healthy, they're invincible. And so again, in that scenario, you get into sort of a slippery kind of conversation about the appropriate screening of high competition athletes. How in depth do you go with that? Does everybody get an EKG? Do individuals get echocardiograms? Obviously, you take a good history of family history. Sometimes there's a history of sudden death in the family at a young age, and that might help identify some of the forms of cardiomyopathies that we have to worry about. But again, that's a tough one. And again, when you look at the resources to screen everybody, everybody who's a young athlete, I'm not sure the resources available for everybody to get an echocardiogram, but certainly that's one of the things that you have to look at. But a good physical examination, at least, where someone's auscultating the heart, here for heart murmurs, taking a good family history about, what perhaps has occurred with other family members, is a good beginning. And then obviously when people do have issues or problems, to extensively look into that, to evaluate that. And it doesn't always mean that the athlete's not going to be able to compete. It's just a matter of doing the appropriate work and the appropriate evaluation of the significance of the condition they may have. As we get older, and for the non-athletes, I think, men in general perhaps have less of a tendency to get physical examinations and to be screened. And so I think that's just another area where we have to continue to work to encourage young men to be seen for physicals and get their basic numbers evaluated and checked and know what those numbers are and to act accordingly with those numbers. To educate individuals that, you can have medical management and treatments that won't affect your lifestyle and your ability to do the things that you want to do. So I just think it's important, again, that we educate our young men, that it is important that we get physical examinations, that we're screened, that we act on those numbers, that we're compliant with those numbers. And then again, back to the basics, watching the nutrition, watching our social habits in terms of alcohol, tobacco, social drugs, and exercising is extremely important that we master those entities in terms of helping to keep our young Black men healthy and young females also, but we were specifically talking about our men.
Thank you. One of the things that I want to talk about, we talked about personal responsibility, but how do we separate personal responsibility from systemic reality?
Thank you for watching and listening to episode 2 of Running Out of Time, Why Black Hearts Are Failing Sooner. Episode 3 drops next week, continuing this important 4-part series with deeper insight, practical guidance, and the conversations our communities need to hear. Please share this episode with your family, your friends, and anyone who could benefit from this information.